I'm Chris Duff. You're in Mackin Museum today with Anna, and it's the 30th of January 2013, and I'm sure we're going to have a very interesting conversation. So maybe we can start off, Anna, by you just telling me when you moved into the Coquitlam area.
I moved here in 1977 when my husband and I bought our first house here.
Or the first house, and at that time were you involved in nursing?
Actually started nursing in 1965. Went into training at Riverview, and then it was still Essendale at that time. It changed just after I came into training. So I've actually been affiliated with Coquitlam from that time.
Right. So back in '65, then you joined the profession of psychiatric nursing, and you were telling me before you trained at the hospital. Is that right?
I trained at the hospital, and I graduated from there, and I retired from there in my 37th continuous year.
Right. So could you tell us a little bit what it was like to train as a psychiatric nurse right back in the '60s?
It was very different than the training now because it was very regimented in a lot of ways. We lived in residence. You had no options unless you were a married student. So we moved into the nursing residences, and we were allowed to go home on weekends if we had our parents' address, but you just didn't go away for weekends.
Right.
And you came back, you had set hours when you could go out of residence. You had to be in at 11 o'clock at night. Or you could stay out for 4 midnights a month, or you could trade in 2 midnights for a 1:30 pass. And you had to be in. When you left the residence for any reason, you had to sign out in a book. So they always knew where we were. They were very protective of us. We had very regimented, uniform policy that you adhered to.
That's quite a bit different to what we have these days, isn't it?
Very much so. Very much so. Our dress policy was adhered to in the way we wore our hair, everything, the length of our uniforms.
So they provided the uniforms for you?
Uniforms were provided? Yes, yeah.
Gosh, quite a difference to today's society, isn't it? So thinking about the training itself, that went on for what, a couple of years?
2 years.
So that was a mixture of going on the wards and classroom activities?
It was, yeah. You went into the classrooms for a period of time, and then you went on to the wards and put everything into practice.
So did you go run on the wards pretty well in the first week, or?
No, you were in classes.
So how long did you go in the classroom before you actually went on the wards?
Our first set of classes was at least probably a couple of months. Well, we started off, I started in September, and then we went in probably after a month, so we went in on very controlled programs. Yeah.
So,
and then we would go back, again, we'd go back to the residence after. We'd go to classes, we'd go there, and then we'd go back. Spent some time on the ward, and then we went back into classes for a period of time. Then you go on to another ward. Most of the time, your rotations were for 3 months on whatever ward you were sent to.
Oh, so it was kind of like, so much ward time and then so much school and
yes, yeah,
sandwiched together.
Yeah, so because whatever you were learning, then you got to go and put it into actual practice.
Right.
But again, our rotations on a ward were only for 3 months at a time.
Oh, I see.
And then you go to a different area altogether. So you could start off like in a long-term female area.
Mm-hmm.
And the next one you could end up on a geriatric ward. Or then you could go off into some other area. So you always got an opportunity to move around and get experience in all the areas.
So over the 2 years, did you more or less cover all the areas in the hospital? Or?
I did.
Right.
I did. And we also went to Woodland School. We did a rotation at Woodland School as well. And moved into the residence at Woodland School while we were there.
And at that time then, Riverview in those days then was looking after people who were maybe had dementia or were there due to, say, old age, as well as young people who had some sort of mental illness?
Well, are you talking about during my time period there?
Yes, I'm thinking right back in the 60s again, yeah.
Well, they had a long-term male building. They had a long-term female building.
Right.
They had integrated admitting buildings. They had building on the other side, in the Valley View side, which was for geriatrics. They had a North Lawn building, which was originally was set up as a building specifically for treatment of patients in the hospital that had tuberculosis.
Mhm.
Then it changed from there and it went to more of a medical model. You had Crease Clinic, was for acute psychiatric admissions. So there's a wide variety of...
What a wide variety
Very
of
much
patient
so,
mix,
very
from what
much
you're
so.
telling me, yeah. Yeah, because I'm just sort of thinking, I suspect if you went out and did a straw poll and asked people now about Riverview, most people would say, oh, well, it was just full of people with schizophrenia and things like that. They would probably forget some of those other things.
Oh, absolutely. And things
Yeah.
evolved over time to meet the... One of the things people I don't think people really understand is the whole idea from the time that hospital was first built, it was responding to the needs of the community.
Right.
And like I say, when you start the very first history back in, well, we always say it started in 1850
Mhm.
in Victoria, but then when you trace the history and then how it went into I don't know how in depth you want me to go, but it was moved over into New Westminster, and then, you know, they purchased 1,000 acres of land out at Riverview site, and then the building was erected, and then there was another one and another one, and it was always because of the needs of the community. So everything was responding to whatever worked the best. And then for a period of time, they even completely renovated a building. One time they used to call them an organic brain syndrome program, which is people that had any kind of traumatic brain injuries or Alzheimer's, dementias, anything like that, that couldn't be managed in a general hospital type setting. So they would get referred out to our hospital. So there was a program in a building specifically set aside for that.
Right.
Over time, people became more adept at caring for people with, with those kind of diagnoses, and medications were better, approaches were better. So we didn't need a full building. But what the community was always saying is we need more admitting beds. So they moved that program, downsized it, moved it around. They re-renovated that building and turned it back into an admitting building. So there was always fluctuation
Of course. of
to
course.
respond.
So really thinking back then to the 60s again specifically, were you actually taking people from all over the province at that time? Or
It was the provincial mental hospital.
Right, exactly. So then really, it had to cater people from northern BC or the Okanagan.
They came
or
from
whatever.
everywhere.
Right.
Yes.
And then, like you said, obviously over time, there were things changed according to the needs of the patients and so on.
Mm-hmm.
Yeah.
Yeah, but the thing is, see, like Crease Clinic was purpose-built.
Mhm.
When it was built in the 30s, that was a veterans block. So that was for veterans coming back from the war that had any kind of psychological needs. But then it changed because they needed more for treatment sort of things. So they changed that building, took the blueprints, and they flipped the blueprints for that building, built a center entranceway. They moved the veterans to a building down on Colony Farm. 1949, they opened Crease Clinic. The Crease Clinic of Psychological Medicine, after Arthur Crease, who was the doctor at the time. That was a totally different treatment model than for the rest of the institution, because it was on the idea that you were only there like for 3 to 4 months. That was your maximum stay.
Mhm.
Whereas for the majority of the buildings up on the Essendale site was like long-term. West Lawn was long-term male, East Lawn was long-term female, and then you had Centre Lawn, which was a mixture for admitting. But primarily, that was the whole focus for Crease. They had much, much smaller wards in those days. When I was there, it wasn't unusual to have a ward of 150, 175 patients. Crease Clinic, much, much smaller, and a lot higher staffing counts. But that's the way the model was set up. And that changed over time as well.
Yeah.
So,
So obviously treatment models change.
Absolutely.
Yeah. Now, actually thinking back there again to those days, do you think that the powers that be, who was, I guess, the provincial government at that time, do you think they paid an awful lot of attention to what ordinary people in the street when they were building facilities, or do you think it was largely, experts, doctors and things like that who got to decide on how it was structured?
When the hospital was at its peak, you have to remember that was a community, very much a community unto itself.
Right.
So all the decisions and things that were made within, right? When they started deciding that they wanted to downsize, and you brought this whole sort of boarding home movement in where people could move back into the community, that made a great change. because now you're talking about moving people back into the community who've been cared for in an institutional setting. They had Burnaby inpatient unit was set up in at Burnaby in Wellington and Canada Way, sort of the flagship model for community-based psychiatric care, and they proved that it could be done. And that's where a lot of this started happening. Then you started seeing mental health centers, and then everybody started getting involved.
Right,
And it
so
kind
there
of
was kind of devolution of mental health.
It certainly
and then
was, yeah.
You got a lot more people interested as opposed to the centralized model, do it all in one place.
Yes, they even when I graduated, they sent a group of staff for further education to learn to do community-based psychiatric nursing. So you would work in a community setting as opposed to being in the institutional setting, which was a great thing. It was a great opportunity for people to move out, and it was that whole different concept for treatment approach. But by then they had a lot more medications and things were coming in. Medications really didn't come in until 53, 54, when they brought in chlorpromazine or lorjactol. That pretty well revolutionized. It was like sort of the focal point for the change.
So
Because
pharmaceuticals just had a huge impact. On
massive,
mental health.
massive, because after you had that, you had a number of other medications started coming in very quickly. A lot of them were coming in when I was in training. In the 60s, you saw a lot of new medications coming in. And then over time, I mean, they just kept improving and improving. And a lot of medications that they used, they didn't use any longer because they had all these newer ones that were coming in.
So then if you think about what it was like then in the mid-60s when you were training, when you graduated, and then you retired, when was it, at the end?
2001.
2001? So thinking about your practice as a nurse then, presumably major changes over that 35-year period.
Well, when I went into training,
Yeah.
you would walk on a ward and it was not, like I say, unusual. You could have 150, 175 patients, sometimes higher, and you did not have high staffing counts. It wasn't unusual. You might have 5 on days, 4 on afternoons, 2 on night shifts, something like that. When I retired, and this was over a period of time, and you had wards were like maybe 25 bed ward. They would take one ward, massive wards, and they divided them. So you'd have two wards from one ward, but the counts were cut down and down and down. So like I say, instead of having a ward with 150, you'd have a ward of 25 beds. Massive difference. Massive difference.
So
and much higher,
ward, but
much
so
higher staffing counts.
So the staffing was better when you retired than when you started?
Oh, absolutely.
Right.
But along with all of the things that when they were doing that, they brought in all kinds of other treatments came into place. All kinds of different programs came in that they did. They had a lot of programming and things for patients. From the very beginning, that was always a big thing at the hospital. Even when they didn't have a lot of medications, they had occupational therapy, they had recreational therapy. All of those things were in place to give patients an opportunity to be involved. They had all kinds, in those days, like work programs. But they weren't meant as like work things. It was giving people an opportunity to have a purpose. You know, so patients would go off to work programs. They could go down to Colony Farm and work on the farm. They could work in a number of different trade programs in the hospital. So they had a sense of purpose. It gave them something.
And if you look at how things developed in that during the course of your career then, those programs, which I think many of us know about, did they increase, stay the same, or in fact did that decline over time, those type of activities, occupational therapy, for example?
Oh, it was huge.
No, but
it was huge. It improved.
So it was improved what they actually did.
Absolutely. Absolutely.
The reason I ask the question is that what you often hear from people now on the street is they say, well, there's an awful lot of people running around the streets who should be in a place like Riverview, and where is the care for them? And then when you look, for example, as you know in this area, Fraser Health's the health authority, and they do have some facilities like Colony Farm, but there's an awful lot of people, some of whom I come across personally, they're out in the community, but there's not really all that much for them, if you know what I mean.
There's no sense of purpose.
They're living on a disability pension, so they have very little money, and there's not much for them to do, and not much therapy they can do, because as you're probably aware, you know, a lot of the therapies you could have, you've got to go out and pay for.
Yeah.
They're not there just for the taking.
Yeah. Well, when I say that Riverview was a community,
Yeah.
that's exactly what it was.
Mm.
You would go there. They had there was what they call Pennington Hall, was the main recreational center. Every Friday night they had dances.
Mm.
Every Saturday they had movies. There was a bowling alley there, but there was a coffee shop there. It was a fully equipped gymnasium. Patients all had access to that. If you didn't have ground privileges, staff would take you down there. That was one of the things we did as students and staff. You went down, you escorted patients to dances, you escorted them to all of these different things. You had programs, so every kind of trade that you can think of in one of our buildings. They had paint shops, carpenter shops, shoe shops, metal shops.
Yeah.
Patients were referred to those kind of programs. You could go and learn a trade, or you could improve your skills in something that you already had. The occupational therapy department, there isn't anything that you can name that they didn't have there. They had sewing departments. They had, there was everything. You could go down to Colony Farm and you could work in any kind of thing, as if you were going to a job. There were patients that went out and worked on the, they called them the long gangs in those days. There were staff specifically hired to work on the grounds. The grounds were magnificent. We have this, the first botanical garden in Western Canada was established on the Riverview site. Magnificent grounds, and patients used to work on those grounds as well. What would happen, it gave people the opportunity. You got up in the morning, you go down for your breakfast, you get ready, you went out to work. You went out to something, you had a program of some sort, but when you came back, and you go with the staff, you'd have a break, you'd have your coffee break, you'd have your lunch, you'd have your, but when you came back to the ward, you had accomplished something. You could come back in the day and you could sit down and say, Pete, you know, how was your day? And you could talk about, every patient wanted to talk all the time, but at least they had an opportunity to say, I did such and such. They actually put in a day's work, or they accomplished something. It gave them a sense of purpose, because otherwise, what did you do today? Nothing.
Yeah.
You sat,
Yeah.
you know, or you maybe had a TV on. It could take a person away from a ward environment. The wards were, like I say, the wards were very, very large, and it was very difficult to have, you know, when you have that many people on a ward at any given time, you can't give everybody a lot of individual attention, especially when you've only got such short staff. But you found them starting to put different groups on the wards. They would have different group therapies on the wards, and all kinds of activities started growing. They had occupational therapy on the wards themselves, in addition to being able to go off to programs in other buildings.
The way you describe it, I mean, I guess it sounds, you know, the actual wards were very big, maybe a bit impersonal, not much attention, but then the activities that people were going off to every day were quite meaningful.
Absolutely.
And I guess really, you know, what you hear many times now, you know, in the press or whatever, you're reading an article that the people, you know, they get up in the morning and, you know, what are they doing all day? Basically not much. There's pharmaceuticals who are controlling their behavior, but they're not actually really doing that much. And then, you know, if they try and go out and they want to, you know, get some group therapy or something else, often it's not there for them. So it almost seems to a layperson like me, you know, that there was a lot more there then, even though it was a large institutional setup, but there were activities that people could join in on, which gives people a sense of meaning, where often now there isn't much meaning for people at all, you know.
Well, there isn't. And there were all kinds of therapies.
Yeah.
That patients had access to, and you had all your psychiatrists, your psychologists. You had all the. We had even pastoral care. Mm. They were there on the grounds. They provided all of those services. Everything was available on the ground. So a person came there, and there was always staff that could see if something was happening with somebody, and you could always find somebody to talk to. So that whereas today, people get lost. You don't have someone that can come up and say, Peter, you okay? You want to sit and talk? Do you need something? You could see if somebody was starting to fall apart. You could see if people weren't eating well, if things were changing with people. People weren't at risk. When you have such a large institution, perhaps, things could happen, and sometimes people didn't like each other, and you can have those kind of things happen. But they weren't at risk. People were in a protected environment. We also had staff, the security staff, that were on the grounds 24/7. What you have today, you have people out on the streets, and they wander. Most people, either, if they're lucky, they're on a disability pension. But when you think about what that gives you at the end of the day, by the time if you've got housing, affordable and safe housing, you can't go to a movie, you can't go to a dance, you can't probably go somewhere and just have coffee and socialize with somebody, because you don't have that kind of money. Whereas there, you could go to all of that.
No, mine was very limited experiences. People have no money, and then they're reduced to things like calling crisis lines and giving them a cry for help, saying, "Oh, fine, I'm gonna blow my brains out or go and hurt somebody," and then of course you can imagine what happens then. That stirs people up to send, the police round or do something else. But it really is a band-aid. It doesn't really do anything to deal with the underlying problem.
Well, they often talk about this dine and dash thing, and but people do go in sometimes, and they take things. Sometimes they're just hungry. That's just a basic thing. They're hungry. They don't have any money. So what do? So they take food. And sometimes people steal, and there are people that are really in serious difficulty. We didn't talk about dual diagnosis with people with a psychiatric illness and drug addiction. Some people have, but nothing like we have today. I can remember in the 60s down in Crease Clinic, we were getting young teenagers in. But that's the time when they were doing, LSD was started in, and marijuana, and all of these sorts of things. And these kids would come in, and you'd get them well, and they go back up. But we say to them, you can't do this. You cannot go out and do this again. And some of them never came back. Some came back. It took longer to get them better. Some of them never got quite to that same level. And some learned, and then they didn't come back. Some came back, and some never left. So sometimes you can look back in histories, and people had sustained years of an illness. But what you see today, the type of drugs that people are taking now are horrific. They are absolutely horrific, and they are damaging people. And some of them they're not repairable. And that's one of the greatest tragedies we have in our society. And a lot of people, they don't want, you can have services available for people, but a lot of people say they don't want it. And, then you can get into this thing, like, do I have the right to be mentally ill? Well, yes, I do. I'm not hurting you, and I'm not hurting me. And if you could, depends on how your attitude is towards it. But can you force me to take medication? No. And if I'm refusing to take medication, what can you do? You used to be able to have people, you could commit people for involuntary care. Was that a bad thing? It's possibly in some settings it was. But on the other side of it, you actually got the opportunity to try and help people. You assisted people to get better.
But
you didn't cure them,
days,
but they got better.
Even in those days, you must have had people who just didn't want to take their medication.
Absolutely didn't want to.
And you couldn't make them, so.
And today, like I say, if somebody doesn't want to go into any kind of therapy, it's very difficult. Then you have people that really want to, and there isn't any place for them. There aren't beds available. And you hear this all the time. They have family members at home. Or they have family members lost somewhere, and you can't reach them. And when you do, you have no place for them to go because there isn't an available bed. That's one of our tragedies of our society today, because we don't have enough beds. They have done remarkable things. I absolutely don't discount that. They have done some wonderful things, community-based care and follow-up. It really is. But you have that huge, huge population that's lost. And I think that has to reflect back on us. I think we have to really look seriously at our accountability to people. And sometimes I don't think we serve them very well. I think we have. I think we've done wonderful things. But I think we're missing a lot. And I think all you have to do is look around and you see the number of people that get in trouble with the law and that are on the streets and then they're in the bushes and they're all over the place, you know, and very, very ill. And now physically ill on top of having a psychiatric illness.
Sure, it doesn't do much for your health living on the streets, does it?
No, no. But a lot of them have serious physical illnesses. And how do we correct that? People don't always like to admit they're wrong. And I think there were wrong decisions made a lot of times when they started moving people into the community. Not because of the decision to move people into the community, but because they didn't have the resources in place. You have to have everything in place before you proceed. You can't proceed and then go, oh, gee, we should have had, or we need more, but we're doing that today. And we did that from the beginning. We always needed and needed and needed. So the community always, like I said, it always responded. We built buildings, we built more buildings, provided all of this stuff, and then we went the other direction. And we're going to downsize, and we're going to move people into the community. It's a wonderful concept. But you have to have things in place before you do that. And it was very difficult learning curve for society.
So when did placing people in the community? When did they start using that in a big time way?
It became very big in the '60s.
Oh,
it
got started even then.
Yes, yeah.
So the patient count at Riverview then would have been
was declining.
Going
absolutely.
Down and even
it peaked in the '50s.
Right.
It peaked in the '50s, but then it started decreasing, and then, like I say, they started all kinds of programs and moving people into boarding home programs and different things, and then they eventually got to the point where they were saying each general hospital should have a psychiatric unit within their own hospital, and they were looking at community-based care and really looking at regionalizing everything. It was a great concept, but it goes back to the same thing. You needed to have the resources in place, and there was never enough, or else you get funding, and then the funding was gone. And this has happened time and time again. It sounds wonderful, and it is a great concept, but you have to have it done very, very well, and you have to have it that it can be sustained. And you hear all the time different programs that are in place. There's just this one right now that's in the news about for the drug and alcohol treatment program. Yeah. It's an amazing program. And now it's stopping. Now what's going to happen to all of the people that are there?
Well, it's stopping because there's no money?
Because they say the funding's gone. They've stopped the funding. But that's happened time and time again. So you have to see, you've got to learn by mistakes. You put these things into place, put them into place properly, and then you have to sustain them. And is it costly? Yes, it is. But then you have to look at what's the cost of human life. And you can't discount that.
No, and I'm sure you're familiar with this argument that, a lot of those people out there on the streets, there is a cost for them. It's just that people don't care to measure it. If you look at the policemen running around putting them in jail, or the jails holding them, or whatever else there is, or putting them into an acute care hospital because they're really sick, those costs are really there, but they don't tend to get measured properly.
They don't. No, they don't. Yeah, it's a horrific problem. And the police shouldn't have to be in a position where they're always dealing with people with a psychiatric illness. That isn't their area of expertise. They do an amazing, amazing job considering what they have to deal with. They do have a number of programs now where they have nursing staff and things that go out and respond to these emergency systems and things like that. That's a great thing.
Yeah.
Do they have enough? Absolutely not. Absolutely not.
Yeah.
So you have people put in very difficult situations. And realistically, some of the people that are out in the community shouldn't be in the community. They should be in care. In care forever? Absolutely not. But they should be in care till you can get them better. Not cured, but you can get them better.
I guess really you want to get people to a point where their condition is manageable.
Absolutely.
And I think, one of the things that I've read from some states, actually, would you believe, in the United States, that they've argued, I think Washington said, well, if you put a roof over somebody's head, you're going to see huge improvements right away, because somebody's actually not sleeping rough, they've got a proper place to call home.
That's right.
It's a lot easier then to deal with them and talk to them about getting them into a program than if they're just wandering around the streets all day.
It's a basic sociological concept, isn't it? It's the basic needs. I mean, they're so basic, but they mean such a great deal to a person. And then if you add on all the other layers, then you have a whole person. But it's very, very difficult for society. Mental illness isn't, it's not popular. Do you know what I mean?
I do indeed.
Like cardiac, huge, transplants, kidney, all of those kinds of things. And I agree, they are so worthy and so necessary, but they tend to have more of like people tend to associate that more, that's the things that people tend to get behind.
Yeah,
Do you know
I think I agree with you. I mean, I think what I find is, if you look at BC, for example, if you look at the funding and where the money goes, it often goes to places like Vancouver General and St. Paul's. You look at the reason why. Sure, they have all the top specialists, for example, in cardiology. But then, it's these people, they publish a lot, they get written up a lot, they make films about them. And then, it becomes a lot easier for them to raise money. So when you're out here in this part of the province, and you look at how much, you get paid for anything, whether it's acute care or mental health, it's less than it is in that part. So, there are a lot of inequities from that point of view. And, but then, it's a reality that's in the same way that people want to support the best sports people,
Sure.
the ones that are winning the medals, then they want to support the most illustrious doctors who perform the most transplants and so on. But it always strikes me that, it's exciting stuff to go out and do, complex surgeries on people like that. But if you look at the amount of human misery that there is out there, there's an awful lot of stuff, for those folks with their mental health who don't have a roof over their head.
That's right.
And then that kind of rubs off on the rest of us,
Mm-hmm. And there are doctors, remarkable doctors in psychiatry. He actually goes out, he goes into the downtown east side in the most dreadful buildings.
Yes.
He goes and that's where he sees his clients. A remarkable man, a remarkable humanitarian. Now he's been written up sometimes and he's been interviewed, but that's the exception. You don't see a great deal about the mentally ill. Like you say, it's not glamorous.
It's not glamorous. One of the things that always strikes me is if you look at an elderly, homeless guy, who hasn't shaved and is pretty smelly. I'm thinking of the kind that my daughter used to care for at St. Paul's. They're not cuddly, they're not cute. Nobody wants to take care of them, to be blunt about it.
Yeah, people, it's a thing, like people, if they don't understand or you don't look quite right, or you're acting strange or something's not, what do? People tend to kind of move away, or you kind of look away, and it's like, oh, maybe they won't look and maybe they won't talk. most of the times, if you talk to people, they're more afraid of us than you should ever be of them. And so sometimes you will find they're lovely, wonderful people. They just have a mental illness. They just have a need. But I think we're so conditioned to what people should be that, people get very uncomfortable with something that doesn't fit what they think is normal. And I think that's a real tragedy, but it happens. It happens all the time. And all you have to do is just sit somewhere and just people watch. And you can see how people react.
You think, thinking back in your career again, which started in the 60s, do you think society's attitudes have changed towards the mentally ill, or do you think they've always been like that, that people throw, strange, keep away from them?
I think there's been a very positive shift in a lot of ways, but I think we're still at that point where a lot of people simply don't know how to deal with this. And sometimes if you don't know how to deal with it, then if you just kind of walk away, or you just don't want to talk about it, you can't pretend something isn't there when it's so right in your face. And it is, because all you need to do, if you look at, we don't hear a lot about, you do when you hear about the courage to come back and things, and you hear these stories, wonderful stories of people that have overcome great, great obstacles with, mental ill and all kinds of different things. But you don't hear about the people that every single day these are your survivors. People with a mental illness are survivors. They go to work, they do wonderful things that everybody else can do. But what you hear about is somebody that's done something, and you've got this new show on TV that comes on, and what do they always show? It's somebody that's mentally ill, that's causing chaos, that's violent, that is damaging people or property or whatever. That's what people hear, and that's what people are always reading. And that's really, really cruel.
So maybe then you think it's a media issue that they sensationalize.
Of course, a lot of times, of course it is.
Yeah.
Look at the movies.
Yeah.
It's more interesting to see a TV program or movies about something like that than, what's this movie that just came out? The girl they won awards for, and the fellow had psychiatric problems and came out, and then he met this girl, and she was also had problems. But together, it's a wonderful movie for people to watch, because it shows, how you can come together and you can heal, and be very, very productive. It's a feel-good movie, but it's a realistic one. But like I say, a lot of times what people want to watch and want to read about is the terrible times. It's more sensational. And that's the tragedy. And we perpetuate that stereotype.
Well, I'm just thinking there again, if you go back to the beginning of your career, if you look at the influence of the media then, presumably it was smaller than it is now. I'm just thinking, now you've got the internet, you've got TV, you've got movies, and these things are in your face all the time.
Sure.
We could be sitting here with a tablet each and just be in our face all the time we were talking. Didn't have that back in 65, right?
Not to the degree that we have it now. Absolutely not. The hospital was in the media at varying times for any number of things, and there was a lot of issues around ECT, electroconvulsive therapy, and different things like that. And so you always had things coming up, and and there were stories about different things, but it was never, ever to the degree. You have to remember, too, that we were a community. We were 1,000 acres of this community up there. Well, then it became smaller and smaller and smaller, but what happened is people started moving out. So now it becomes community-based. So whereas before they were always saying, well, let's move them away. And that's what would happen in the early days. People would come into hospital, and sometimes people didn't leave. And you could look and see people that had a 30, 40-year history of hospitalization. It's unheard of now.
Yeah.
It's unheard of. But they were in the hospital. Now, people would come in for short periods of time, stabilize, and they go back out. But you always have that population that doesn't get well. They might get a bit better, or they don't. And they're not being treated, and they are so marginalized. And they're lost. They're lost. And that's where you find that keeps coming up and coming down, all these problems.
So maybe in the old days, one advantage then, it would maybe give people the opportunity to get to a level where at least their condition was manageable and they had some quality of life.
Absolutely, absolutely.
They mightn't be well enough to go live on their own and have their own home, but at least they had some quality of life.
But a lot of people could get well, and they could go. Absolutely, they could, and they did. But you don't hear so much about them.
No, you don't. But
No.
I'm thinking about now is, do you think now that the chances of getting well maybe are less than they used to be? Because
No, I think if people have a better chance, because there is education and there is more understanding in that sense that you can. However, it's getting in to that care. It's accessing it, because you could try and get in for, but there might not be any availability for you to go there. That's the problem. Once you can get in, and there are therapies and there are medications that are wonderful. So you would never ever have to come back into a huge institution. We will never see big institutions again like that.
No.
But there are smaller facilities where you can go. However, if you can't get in to access the treatment, but once you can get the treatment, there are some amazing things that can be done. But it all goes back to the same thing. So you have
funding and the
absolutely,
availability.
absolutely. So then you have this population who get lost, and you have families saying, "I am overwhelmed. I am overwhelmed. My wife, my husband, my child, my grandma, whoever. I don't know what to do anymore." You know, and you have this segment of the geriatric population in terrible, terrible shape. Some of them terrible. Not enough beds. Not enough beds. So families are trying to deal with that as well. You need help. It's a massive, massive problem.
So if you think back there again to the early days in your career, was it actually easier at that time than if you had somebody who was very elderly suffering from dementia? Was it easier to get some care for them then than it is now?
Absolutely.
Really?
We had a whole program, a whole building for the geriatric population. Plus, we had other availability for geriatrics in
Because
different
that's what I'm
buildings.
thinking of now is when I was doing my work around the hospitals a few years ago, the sort of typical comments you get from a director of acute care is, well, we've got that ward over there and they're full of ALC. And I said, well, what's that? And they said, oh, well, that's alternative level care. I said, well, actually what that is, that's somebody we've done as much for them as we can with their physical conditions, kidneys or whatever else it is, but actually, they're not able to go home. They've
Right.
got severe dementia. I said, well, what about it? No, well, actually, no, there aren't the long-term care beds for them. So what happens then? They're marooned
That's right.
in an acute care hospital.
That's right.
They're given very, very basic hotel-type care, not very much nursing, because there's nowhere for them to go.
Yeah, and you see, we had, like I say, they built, there was a whole section at the hospital. At one point, it was called the Home for the Aged. And it was a whole group of buildings and everything just for the geriatric population. So you could be referred there and you were admitted there from everywhere, provincially. Then they built a bigger building, huge big building. So you had that, plus you had the other buildings. So it was much easier to bring people in and get great care. They got exceptional care because the ward counts were big. They had the high staffing counts. In the early days, counts obviously were much higher, but over time they got smaller, and your staffing improved, your treatments improved, your medications improved, everything was better. But you don't have that anymore. So you have other places trying to manage. And sometimes you have hospitals that say, okay, they can take that, but they can't manage the level of care that some people need. They could, like say in our Valley View building. That was their
so
area.
It's a question of degree, you mean?
That was the area of expertise for geriatric care, and it is established and documented and written, acknowledging the expertise of geriatric research and care that was provided. There are some people that just have so many complex care needs, and they need purpose-built, specific programs, and they're not available to the degree that they're needed. So you have a huge population in general hospital beds that shouldn't be there, but there aren't beds available for them to move into for geriatric care. It's a tragedy, because nobody's benefiting it, nobody's winning by that. So, politically, is it a big issue? Should be. Should be, because everybody's going to be touched by it. At some point in time, you're going to be touched by somewhere in your family or an association with somebody with a mental illness, and every single one of us is going to have somebody that's in a geriatric setting.
Well, if you look at lifespans now, it's inevitable in every family.
And it's becoming more obvious now because people are living longer. So, you didn't see the people now that, like in their late 80s and their 90s and older, that are still living. And some are still but some of them are really in great, great need for care. But they don't have the availability. So the people, like I say, they're in various facilities. And not that great.
Yeah, I guess my impression is with that, it depends an awful lot. If the family has some money and they're prepared to spend it, you can get the care.
You can. But not a lot of people have $5,000, $6,000, $8,000 a month.
Oh, absolutely. Sure.
To provide that care. The ordinary person doesn't make that kind of money.
Sure.
And how do you come up with that kind of funding on a monthly basis? Like, it's almost impossible for some people. I would say for most people.
Mm-hmm.
But then at the other side, what do you do? Is that your mother, your father, your spouse? And you have people like Alzheimer's. People with Alzheimer's sometimes are being diagnosed early Alzheimer's, like in their 40s, their 50s, 60s, and are needing to go into care by the time they're in their 60s and stuff. That's very young. That's very young. Because most times, if you're in your 60s, you still have children.
Mm-hmm.
Your kids could be in their 30s, 40s, and you could have grandchildren or whatever, right? We have a friend who's in his 60s, and his first wife died. He married a younger woman. They have an amazing marriage. They have a little boy now. Well, it's wonderful today, but you have to be realistic too. He is going to certainly be, at some point in time, a geriatric individual and likely in need, and he has a young son or younger son, but who knows? That's just one. But what about all of the people that are, like I say, in that younger age group? What do you do? Usually you're not that financially viable. You like to think that you hit a certain age and you can retire and you don't have a mortgage, you don't have all of these things. But if your spouse is diagnosed in their 60s and need to go in for care, then you have that huge huge stress.
Yeah, no, it's probably why it terrifies so many of us, really, that could actually happen when you were that young.
And it is really significant, the number of people, you know, and that's just like sort of just one thing. And now you've got all these kids, all these drug addicted kids. So you have kids that are drug addicted and they're psychotic. You know, so are they self-medicating with drugs to control their psychotic symptoms, or have they gone psychotic because of the drugs that they're using? At the end of the day, it almost doesn't matter. What matters is they need care and treatment. And where do you find that care and treatment? There's never enough. And all you have to do is listen to family members. So it goes from everything from young people right up. You run the whole spectrum up until to people that are in their very, very late ages. People need care. People need treatment. People need understanding. People need compassion. People need a purpose at whatever stages they're at. And as a society, we're not meeting that very well a lot of times.
No, I agree
You know?
with you. I think what's sad about it is that it seems to be in a way getting worse. As the longevity of the population gets greater, the problem grows with it, and there's no new solutions coming forward.
But no, and they talk about it. They always seem to talk about it, but they always don't. And even when they put funding aside, if you don't keep that funding in place, well, then what happens when the funding stops? You can't stop funding and just say, "Oh, there you go, it's over now." Well, how can it just be over?
But that's
The reason the funding came into place, that didn't go away.
But if you think about it, in your experience, that you often find, that funding would come out of the sky, come in for a year or two and go.
And it's gone.
And that's a trend that's continuing now.
Absolutely.
So pretty well all the nurses I've spoken to have all said the same thing. They said, look, we can't live with here today, gone tomorrow. It has to be continuous, because
Absolutely.
otherwise the benefits will not be continuous. But, I guess what you hear from people there is, well, it's so much subject to political whim.
Sure it is.
What do we need to do to get those votes?
It's true. No, it's very true. And I think they acknowledged several times. Like I can remember when I was writing history, there was an article in one of the annual reports from the 50s, and it said, I can't quote it exactly, but it was basically said, Essendale will be well advised to close as it is no longer serving the purpose for which it was built. Well, obviously that didn't happen. And over time, they hired people to come and look at closing the hospital. And what it always came down to was, can't be done. Or it can't be done at this time. It just simply can't be done. Then they made the decision it's going to happen. And it's like, you really need to think. But the decision was made. And it was going to happen. And along the way, it kept getting delayed because things didn't happen like they thought it would happen in timelines. But they were determined. And it happened.
So by the time you actually retired in 2001, how much was still there at that point?
Well, West Lawn closed in 83, so that building was closed. Crease Clinic closed in 92. And then East Lawn closed in 2000. I left in 2001, but East Lawn closed in 2005. North Lawn closed in 2007. And then they just kept gradually closing.
So by the time, I'm just thinking in terms of the end of your career, it was a fraction of the size that it was when you started, when you retired in 01.
No, because East Lawn and North Lawn were still
So they
still
were
open.
still
And they
pretty
were
big
large.
entities.
Yeah, East Lawn was always our largest building.
So really then, in terms of the very sharp declines, and they came in
It's after, yeah.
that last decade then, I
Absolutely,
guess.
yeah.
Right, the decade after you retired.
Yeah. It had certainly was going down. But it really accelerated. Really accelerated, yeah.
So in other words, decisions have been taken long before that, move to the community care. There's the issue about whether there's the resources in the community, but then the actual movement to get people out of there accelerated. And from what one hears, maybe, the need to put resources in the community before you move people out hadn't really improved at all.
Depending on who you talk to, yeah.
Well, exactly. I mean,
But
I
I
don't
think
have the data in front of me.
But I think it shows that it hasn't worked that well. I think what's happening is it's really showing more now, because you're really starting to see where, like I say, all the funding that was available isn't available like in the next fiscal year or maybe the following fiscal year, and that's where people are falling apart. Or you find, like I say, people want to get into care, people want to get treatment. Well, you can get that, but you might have to wait a month, 2 months, 3 months. If I'm in crisis, it's great if I can phone a crisis line, but I need to be able to take my husband, my daughter, my son. I need them in care today, like right now, because it's out of my control totally. I don't know how to help my family member. Well, so what? If I can't get them anywhere, or I can get them down to emergency department in a hospital and get them assessed, doesn't necessarily mean that I'm going to be able to get them admitted, because if there's no bed, so you can give me a prescription.
That's right.
But if I say, okay, you need to take your pill, and I tell you, I'm not taking that, what am I going to do? Or if my kids hired a kite, just absolutely, and they're gone. And how many times you see parents are downtown East Side hunting because these kids they're lost. Or you have family members that are, so psychotic, but they're not harming anybody. Well, I guess it all depends on how you want to look at that. Maybe they're not physically harming anybody, and maybe they're not physically harming themselves. But is that really true, that they're not harming themselves? I don't think so.
Just as we close today, I'm just thinking again, if you look back at your career again, which was quite extensive in mental health, what did you find, that was the biggest satisfaction for you over your career? When you retired, what was the thing that gave it the most meaning, do you think?
Believing that I really made a difference.
Yeah.
And I believe that I did, and I believe I was a part of very positive change in how people were cared for. And I think it was very positive seeing changes where people did get to go out into the community and how there was a degree of acceptance. I think that was all very positive, and I was a part of all of that. So yeah, at the end of the day, I think I contributed, and I think for me, my legacy is preserving the history, because I think people have to understand the history. I think the history will tell you where we came from, and it tells you where we're going, and it acknowledges what we did positively, and it acknowledges the mistakes that we made, and I think you have to do that. And I think it will reflect on us as a society, how we're remembered. And I'd like to think that I was remembered positively.
Well, I think I could share pretty well all those sentiments. So thank you very much for talking to me today, and we're all done, I think.
Okay.
Thank you.
Oh, my pleasure.